Okay, let's start. It has turned 6:01. So hi everyone, and welcome to the Dharma Sydney branch webinar, Applications of AI in New South Wales Health. My name is Varun Pant, and I'm the National Secretary of Dharma, besides being the Sydney branch president as well. Can I please request you to put your name and location in the chat window so that we understand from where you're all joining today? Please also note that this webinar will be recorded. I would like to acknowledge the traditional owners of the land from where we are presenting today by acknowledging elders past, present, and future, and pay my respect to all Aboriginal people joining us today. So please, feel free to use the chat feature of this webinar to interact with all the attendees, and please ask questions. The speaker has specifically requested that please ask questions so that there can be more interaction. So questions to the speaker need to be placed through the Q&A option. I would highly encourage you to use the chat and the Q&A, and for users to also like the questions so that we would prioritize the questions based on how many people are liking it. And it gives me immense pleasure to introduce to you today Lachlan Rudd from New South Wales Health. Lachlan, if you can turn on your video, please. Lachlan Rudd is New South Wales Health's Director of the Data and Analytics portfolio. This portfolio coordinates all data and analytics related projects within eHealth New South Wales, and which is growing in number and importance as progress is made towards the implementation of eHealth strategy for New South Wales and the New South Wales Health Analytics Framework. Lachlan's previous experience was as product owner at Quantium, a company that specializes in the development of AI-driven big data products. Prior to that, Lachlan worked as a research projects officer at CSIRO's digital productivity flagship. Earlier in his career, Lachlan was director of a Beijing-based investment advisory firm specializing in China outbound investment. Lachlan holds Bachelor's of Business, Finance, and Mandarin Language, and Masters of Mathematics, Applied Statistics degrees from Queensland University of Technology. So welcome once again, Lachlan. And in today's presentation, we are going to be discussing the applications of AI in New South Wales Health. Over to you, Lachlan.
Hi all. First of all, a big thank you to Dharma for having me here today. As Varun foreshadowed, my presentation is around the applications of artificial intelligence in New South Wales Health. So just give me a second to share my screen. I've got a presentation for you all today. That's okay, right, Varun, to share now?
Yes, please.
So I guess the interesting place to start is what AI actually is. And from my perspective as a statistician, it's a marketing buzzword. The kinds of things that are labeled AI today were the statistical models or machine learning models of yesterday. True artificial intelligence, that general purpose artificial intelligence, where it can take a complex set of instructions and creatively come to a solution, is the stuff of science fiction and sometimes science fiction nightmare. What we're using today are pattern recognition engines that are able to do things in a black box sense that humans very much struggle to do and unpick the nuanced ways that different concepts interrelate with each other to come to quite specific predictions of the future that are in many cases accurate, but they're not self-thinking, self-reasoning. So that's the first thing that I think was worth covering, is just that definition of AI. But the project that I want to bring to your attention is around sepsis management in emergency departments in New South Wales Health. So a sensible place to start is, what is sepsis? So sepsis is a condition of the body. It's not actually a disease itself. It's when you are infected with something and your body responds to that infection. Historically, before the advent of modern medicine, this was often a life and death situation. So bacteria may be growing in your blood at a record pace. If that culture takes hold, you will die. So your body responds as hard and as strong as it can to fight off that infection. And unfortunately, the reality is that with a response that strong, it can sometimes kill or permanently harm the individual who's fighting off that infection. From an evolutionary standpoint, excellent response, great, it saves more people than it hurts. But in today's world, where we have a little pill, an antibiotic that can do the job just as effectively without doing any damage to the body, you really don't want a septic response to any form of infection. So the risk for a patient presenting at an emergency department waiting room who already has sepsis is a 20% chance of dying from just walking through the door. That's their baseline risk, according to the peer-reviewed international literature. And the longer it takes to identify and treat sepsis, in the case of bacterial sepsis, as I was just describing, an antibiotic, but you can have a fungal infection or a viral infection, which would require an antiviral or an antifungal. The longer it takes to treat that particular infection, the greater the risk of death increases, all the way up to about 40%. And it's not just death that's a problem here. You may survive sepsis itself, but be left with a debilitating lifelong chronic condition as a result of it, or go through a horrific stay in an intensive care unit at a hospital where you are on the brink of death, attempting to recover from this particular illness. And when you look at the alternative of being able to detect it early and a simple intervention that costs you cents on the dollar with zero side effects, it's quite clear the path that you'd like to take. Previous work in New South Wales Health, there is a lot of previous work in this particular area. Sepsis is a priority focus for almost every health system around the world. What we have in terms of early sepsis detection is called the Sepsis Kills Program, developed by a pillar organization of New South Wales Health called the Clinical Excellence Commission, whose primary focus is on patient safety. Now, the Sepsis Kills Program is an old paper-based tool that hasn't been digitized as yet. There is a program to slowly digitize it. And it focuses further down the clinical workflow. So while the project I'm going to talk to you about today focuses specifically on the emergency department waiting room, the Sepsis Kills program is for patients that are already admitted to the hospital or already in front of clinicians. The big risk for those patients in the waiting room is that they haven't been seen by a clinician. Their risks are widely unknown, and they're almost guaranteed to not be being treated because the clinician hasn't seen them as yet. If you look at the Australian-wide statistics for sepsis, you can see it is a very serious condition. You get about 16,000 ICU admissions across the nation per year with a sepsis diagnosis. The cost per episode is around 40,000 Australian dollars. There's 60,000 total cases of sepsis in our hospitals per year, resulting in around 5,000 deaths. And you can see a bit of a disparity between that 20% death rate I listed on the left and that 5,000 deaths on the right. And it's because that was a conditional probability, to use statistical parlance, on the left, which is the risk of death for someone who is admitted to the emergency department with sepsis already present. There are a number of people who will develop sepsis further down their hospital journey, but luckily when they're admitted to hospital and being observed by clinicians, there's a greater chance of detecting it and treating it earlier, so that risk of death is lower, but still not zero for those patients who do contract sepsis further down the chain. And if you contrast that death figure to other national death statistics, you can see that it's larger than the annual national road toll, larger than breast cancer, larger than prostate cancer, larger than colon cancer, but you don't hear about it as much. I can't speak to you as why. Probably the big reason is that sepsis isn't a disease that can be beaten. It's inherently a part of us. It's a response that our bodies just have, a response of being human. So there's not too much we can do about it other than identify its signs early and treat whatever underlying disease or condition is causing that sepsis response. The project that I'm going to take you through today is a project of two parts. The first part was an Internet of Things device integration body of work, and the second part was actually the AI product itself. The presentation today focuses on the AI product, but I think it's worthwhile I'm giving a bit of an overview of what that first part was, because it's very relevant if you want to deploy these kinds of AI products yourselves wherever you may be working within Australia or the world. So within the emergency department, the way that the workflow works is a patient will come through the front door. They will go to a registration station where their basic details are taken, name, address, Medicare number, etc., and some information around their presenting problem, and that goes into the patient admission system. And then there's some additional tests taken around that patient's heart rate, blood pressure, temperature, etc., which can help with that triage decision of who you should get in front of a clinician first. And that's what emergency departments are all about. They're chaos, where different people with different levels of severity for their presenting problem are all sitting in a waiting room together, and it's up to the doctors to work out who needs to be seen first. So the problem that we had applying artificial intelligence to this particular area of the hospital was the timeliness of information, particularly around those measures of patient vitals, blood pressure, temperature, heart rate, etc. The way it works today is still very similar to the way that it worked back in the paper-based world, where a patient goes to a nurse station and there is a dumb device sitting there that a patient gets strapped into, and that device will read out blood pressure, temperature, heart rate, etc., but just read it out onto a screen. It's then up to a nurse to write that result down on a piece of paper next to the name of the patient that they were recording an observation for. And they may see 5 or 6 patients back to back before they eventually go to the computer and enter all that information. If we're deploying an AI algorithm that relies on this information to make good predictions, our predictions are going to be whatever time period it takes that information to enter the electronic medical record delayed, if there is a delay in that process. And as the previous slide highlighted, timeliness is critical in the treatment of sepsis. Every minute, every second potentially can be a contributing factor towards a risk of a patient dying. So if we're in a situation where we're waiting 20, 40 minutes for the basic information to arrive, that's 20, 40 minutes that we can't diagnose sepsis and get that patient treated. So the first part of this project was a collaborative initiative with New South Wales Health Pathology to retrofit these dumb devices with Internet of Things capability, automatically record the information collected by those devices, link them to a patient record, and through an IoT gateway, push them into the electronic medical record where they'd be ready for consumption by an AI algorithm within seconds instead of up to an hour potentially. This IoT architecture had use cases beyond simply this project. It was a reference architecture for the state. New South Wales Health Pathology manage a range of pathology devices in very remote settings. They're not always contained within the 4 walls of a hospital with access to hospital Wi-Fi. So there's huge merit to this particular reference architecture more broadly for New South Wales Health. But for our particular project, it solved that specific problem of timeliness of information. Now, we finished the proof of concept in this space in 2019. So we've demonstrated the capability of this particular tech. Unfortunately, COVID did hit towards the end of this proof of concept for this component, which did delay our implementation of the AI algorithm itself. So we've got this unfortunate disconnect where we did the IoT first, and now we have to trial the AI separately, coming up in a month or so's time. But I just wanted to cover that there was an IoT component to this project and highlight the reasons why that really focused on the timeliness of information. But if we discount that and just assume all of our information is available within the electronic medical record when we need it, all the information that an AI would need to detect sepsis, the way that the workflow works for this particular product is a patient is registering at the emergency department. They're having those basic tests performed, so blood pressure, temperature, heart rate, etc. That information is entered into the Cerner system, which is the electronic medical record, which also contains their historic information as well. So information on their pre-existing conditions and previous trajectories through encounters that they may have had in days, weeks, or years past with New South Wales Health. What our AI model does is pull this information together and come up with a prediction of who is most likely to have sepsis. It incorporates this prediction into a front-end product for a person in the emergency department waiting room known as the front of house coordinator. It's the role of this nurse to observe the people in the emergency department waiting room and look for deterioration. So when a person first arrives, there's an assessment of what their triage category is and where they sit in the line to be seen next by a clinician. But obviously people can get worse fast in the emergency department waiting room. So the front of house coordinator's job is to pick up those people who are deteriorating and get them in front of a clinician as soon as possible. And what our product does is give a risk for every patient in the emergency department of a risk of sepsis, provide a risk stratified list of patients to that front of house coordinator, bring in some additional information about why we think that person has sepsis. So the front of house coordinator can combine the predictions of the algorithm with what they're seeing with their own two eyes. Now, this is an interesting point when it comes to any piece of AI that's being, I guess, retrofitted into a workflow that exists today. And that is that the AI is only ever going to be able to see a sliver of the information that is actually present in the given situation. So that front of house coordinator looking and speaking to the patient is going to have a wealth of information at their fingertips that's never going to make it into the electronic medical record. So the AI will never know anything about that component of the information. The AI's predictions will be worse because of that. So what we need to be able to do is create a prediction that allows the front of house coordinator to take it, but also blend it with the information that they have in front of them to come up with a better decision than either the AI or the front of house coordinator could have done by themselves. And the real thrust of our product, what it's trying to do is overcome the human bias of if you're not looking for something, you don't see it. The same way that if a driver of a car hits a cyclist, in many instances, you'll find that driver after the fact swearing they didn't see the cyclist, even though they swerved into them. And this is a very real phenomenon in human psychology, where if you aren't looking for something, you don't see it. So the driver who's actively looking for other cars and trying not to run into other cars is looking only for cars and actively does not see that cyclist. Similar with sepsis, because its symptoms are so minor, very similar to a person experiencing a cold, they may just look a little bit pale, feel a little bit nauseous. It can be very difficult to identify, but it's obviously incredibly lethal. So what we're hoping to do with this product is shine a light on those people most at risk of sepsis. So the front of house coordinator can look at them and think sepsis. So if that person looks a little bit paler over the course of 10, 15 minutes, the front of house coordinator would treat that with more severity than they would with a patient who's just suspected of having, the flu or something like that. Now, in designing our particular intervention, this AI product, we didn't begin with a bunch of data scientists in a dark room working with numbers. We really thought about how can we apply this particular insight to drive value for the patients of New South Wales Health. When we first began on the journey, we were speaking with an emergency department consultant whose entire specialty was around sepsis diagnosis, in the sense that he just finished a PhD on how we can better diagnose sepsis in emergency departments, so an absolute expert in the field. And his recommendation at that particular point in time was that we could use the information available across the patient journey in the emergency department to come up with a prediction of sepsis so good that we wouldn't have to wait for a pathology lab result to turn around. The way that sepsis is 100% ID'd today is that a blood sample is taken from a patient, it's sent to a pathology laboratory. It takes about an hour for that lab to turn around the sample if the result is rushed, and it will come back with exactly what the source of infection is. So clinicians can give a targeted antibiotic or antiviral or antifungal towards that patient to clear up that infection as soon as possible. But what the hope here was that we could, using just the information available at the emergency department itself, come up with an equally predictive measure using a data-driven approach and AI modeling that would allow us to short circuit that 1 hour turnaround and begin treating the patient immediately. But before we began developing this, we started with the human-centered design process, where we embedded a team of human-centered design specialists in an emergency department waiting room, and we followed the clinicians for a week and observed what their workflow looked like. Because at the end of the day, our hope was to push a recommendation to clinicians that they could use to make a better decision that would lead to better patient outcomes. And what we discovered over the course of that week, and with discussions with those clinicians who were on the ground day in, day out working with these patients, was that by the time a patient had been progressed down an emergency department workflow with a suspicion of infection, they were already being treated by so many clinicians under such close scrutiny and with such a high suspicion of sepsis that they would all be on broad spectrum antibiotics anyway. The number of patients that you would treat differently based off of an AI prediction would be very, very low. So the chance of our intervention having an impact in that sense was small. To compound that, There was also the difficulty of reaching the right clinician in the chaos of the emergency department. So while our AI algorithm could send a better alert to the electronic medical record itself, there's no guarantee that a clinician will regularly check the EMR records for every patient currently in the EMR, unless they're actively looking at that patient and adding new information to the record. So even though our algorithm may at a certain point come up with a large warning that this patient may have sepsis, it could be 20 minutes, an hour, 2 hours before a clinician opens that record and discovers the warning. So being able to present the information in a timely fashion proved to be difficult. But in discussions with those clinicians, what was widely agreed was that the emergency department waiting room was entirely a blind spot for them and where the greatest potential risks to patients lied, and where we were able to pivot to this concept of a risk stratified list of patients in the emergency department waiting room that would allow that front of house coordinator to better escalate patients in to see clinicians where they could be given that broad spectrum antibiotic immediately and could go down that standard sepsis kills workflow where a lab result is taken, the source of infection is firmly identified, and a targeted treatment is given in as timely a manner as possible. Now, what I wanted to discuss here was less around our project itself and more around why AI really does make a difference in the context of New South Wales Health. It's not to say that we don't have artificial intelligence by a definition today. If you look back even to the 1980s with the concept of expert systems, where you give a computer a rules-based engine where it always goes through the same decision tree and produces the same results, based on the criteria you pass it. That was at the time considered a form of artificial intelligence. We consider it to be quite par for the course now. And it was very present in our paper-based medical records as well, where decision support systems would use these criteria-based approaches. The reason for using criteria-based approaches in the paper-based world was due to cognitive load. So a clinician in a chaotic emergency department setting doesn't have time to pull out a calculator, crunch a very large logarithmic formula with extreme precision, and come up with a nuanced risk score for a patient in front of them without introducing additional error into that calculation or slowing down their workflow to such an extent that it harms more patients than it helps. So the way that these types of decision support algorithms have been built historically has been to start with a clinical trial and then quite a nuanced statistical model, but then abstract that into a more simplified static boundary conditions type model where you may say, okay, for respiration, so how fast you're breathing, there is a safe range between say 11 and 24 breaths per minute. And anyone who falls outside that range is in a danger zone. Likewise, for things like oxygen saturation of the blood, heartbeats per minute, things like that, you can come up with a safe range for each of those, apply them to every patient. And if a patient is falling outside the safe range for 2 or 3 criteria, it would be a clue that you should look at them more closely and try and work out what's going wrong. But the problem is that this is a blunt instrument. So even for things that we should all inherently know, like blood pressure, you can't just apply a safe blood pressure range for every individual. We know that safe blood pressure ranges change throughout our lifetime. People in different age groups have different safe blood pressure ranges. And you can see in that middle chart an example of that. And this is true for any interaction between any causal variable in a particular process. So you can't say that there's one standard, one safe range that will apply to everyone. It's going to be nuanced based on the unique circumstances of each individual. So the paper-based decision support tools were exceptional for their time. But now that we have computers available to us who can offload a lot of that cognitive load to the central processing unit of the computer and only provide the information pertinent back to the clinicians, we've got a real opportunity to greatly improve the way that we leverage the vast volumes of data that we're collecting. Instead of using these blunt tools we have of the past, still limited by the perceived limitations of the past, we can take that next step forward and really use the information in its entirety and begin to tailor the predictions towards the individual. And if we're able to do this, there's 3 main benefits that we can achieve in the clinical care setting. The first one is a reduction of alert fatigue. So if we do naively translate these paper-based decision support tools to electronic systems, you actually find that they fire alerts for a large number of patients who really they shouldn't be firing alerts for, so false positives. This was fine in the paper-based era where a clinician could use their clinical judgment to look at a patient and just decide that, hey, there's no point stepping down this particular decision path tool. I know based on my experience with this type of patient that it's fine to proceed the way that, that I'm proceeding. But in the digital era, the machine will just constantly be throwing alerts in the clinician's face, telling them that this patient is very ill. And the clinician gets frustrated because they know that the patient isn't. They understand the unique circumstances of this patient. So they start ignoring the alerts. And then the problem comes when a genuine alert is thrown that the clinician should be paying attention to. They're so used to ignoring these repetitive alerts that really shouldn't be there. They switch off entirely and they don't accept the alerts that they should. So alert fatigue becomes a patient safety issue in that sense. And by building more targeted alerts into our systems, we reduce the number of false positives that fire, thereby reducing alert fatigue, meaning the alerts that are present within our systems are more useful to clinicians. Therefore, they're treated with more priority by those clinicians. They're treated with more respect. They believe that they are accurate more often. The second piece that we can look at is fewer missed cases. Again, with these paper-based tools, they're designed to apply to the broad population, but there's always going to be fringe groups of people that don't necessarily represent a large number of the population, but are very unique. And the way that a particular condition or disease presents for that group may look quite different for the wider population. And by not allowing our algorithms to be flexible enough to also account for their unique circumstances, we're going to miss a number of cases. So by taking the step towards AI and these enhanced decision support algorithms, we have the ability to detect more cases, catch larger numbers of cases earlier in the case of sepsis and treat people sooner, hopefully leading to fewer deaths and overall better patient outcomes. And then the final piece is the personalization of care. So instead of treating every patient as just a patient and exactly the same, recognizing that they are a unique individual and there's a lot that we can learn from their medical history and tailor treatments to be unique to them to yield better results for them. And AI offers a compelling opportunity to do exactly that. Humans aren't necessarily great at recognizing these huge nuanced passions and then drilling down to what they mean for an individual, but machines present a very compelling opportunity, especially with the volumes of data we're now collecting within our electronic medical records, to really improve the quality of diagnoses and predictions that we're making at the individual patient level. And a bit of a summary down the bottom of the page here. You can see that AI models can learn from the breadth of EMR data, build an understanding of patient phenotypes, a phenotype being how a patient's genes express themselves. So while it takes time to sample a person's genome and build an understanding of what that means, you can look at a person and build an understanding of their genome based on how it physically expresses. And that's what a phenotype is. And use this to come up with unique risk factors for that individual patient and allow those risk factors to interact with each other in complex ways that were never possible in the pen and paper world, and remove the need for manual computation that was required in the world of pen and paper. And the thing that we really need to hammer home too, to alleviate fear within our workforce, is that there is this connection between AI and computerization and automation and the impact that that has on the workforce. I don't believe that within our lifetimes there will be a replacement of doctors or the clinical process by AI, but there is a huge opportunity to augment clinical processes with artificial intelligence. And this is done by recognizing that the breadth of data that we're now collecting within our medical systems far exceeds the ability for a single clinician to sit down and review in any finite period of time. So while they can skim the highlights, that is really all they can do as they see each patient in a busy hospital setting. But what AI can do is recognize that there is valuable nuance in that historic medical record for that patient, recognize that a decision needs to be made by a clinician at this point in time, parse the historic medical record, condense it down into bite-sized chunks and present it to the clinicians at the point in time they need that information to help them make better decisions. Now, as I said back at the start of the presentation, the AI is sort of looking through a keyhole. It only has that slice of information that is available within the electronic medical record. So it needs to present that information in a way that it can be integrated with what the clinician is seeing in front of them and the information that they're hearing as they discuss with their patients. And the combination of the two is likely to lead to a step change in the quality of patient care that we will see within hospital settings over the course of our lifetime, but not the automation of the medical profession. I'd be remiss to say that eHealth New South Wales, the organisation that I'm from, was alone in delivering this project. We did have a large number of collaborators. Chief among them was New South Wales Health Pathology, particularly for the Internet of Things component of this project. Also assisting with the Internet of Things piece was Siemens, Microsoft, Intel, Deus, and Welsh Allen. Welsh Allen being the device manufacturer who was building that dumb device we were integrating into the EMR through IoT. And then we have our partner organizations. So the Agency for Clinical Innovation is a strong stakeholder. The Clinical Excellence Commission have ownership of the existing sepsis kills program and patient safety at large. So working with them to ensure that the product that we're building aligns with their strategic direction and maximizes its chance of having a successful impact based upon their decades of experience in this space. We also have our local partners at Western Sydney Local Health District, as well as the Sydney Children's Hospital Network, who sit next door to Western Sydney LHD and Westmead. And then from an analytics standpoint, building out these AI models, we have the University of Sydney who've been offering us substantial support. It's probably worthwhile also mentioning that eHealth New South Wales, the organisation that I'm from, where we sit in the grand scheme of things. So eHealth New South Wales is the ICT services provider to New South Wales Health. So we're responsible for working with the Ministry of Health, the pillar agencies who are responsible for things like patient safety, clinical innovation, etc., as well as the local health districts who manage the hospitals and the delivery of care. We're responsible for tying together their ICT strategy and delivering the services that they need to succeed from an ICT standpoint. So that includes things like the delivery of electronic medical records, which we have done quite successfully over the last 5 to 10 years, the digitization of paper. But with projects like this, it's taking it to the next step. Now that we've collected this wealth of data, how do we really use it to do things that we could never do before, to give that step change in improvement in patient outcomes? So I'm going to jump to the Q&A piece of the project now before I can continue. There is more that I can say about this project. I can go into further depth, but I'm happy to take questions. So I've got John from the top asking, will TGA approval be required before the solution can be used in a clinical setting? And the answer would be yes, before we rolled this out widespread as a clinical or medical device, especially if we were doing it outside of New South Wales Health. So if we were to turn this into a tangible product, we would go down that path. As it stands, we're encapsulating this within a research project. So we've gone through the typical research ethics process. We've sought consent from everybody involved. We haven't standardized this as a medical device or mandated it as a requirement for New South Wales Health. But should the proof of concept or pilot, as it is in this instance, prove successful, we would be writing a business case to roll this out more broadly. And a part of that business case would be funding for TGA approval, or at least a review from the TGA, whether or not they thought approval was necessary. The second question that I see here is, can you remind us of how the alerts are delivered to the clinicians? So yeah, this is a good one. So visualize yourself as a clinician today, and it still is a bit of a legacy situation. So you can take yourself back to the 1990s in some instances, where you're dealing with these large CRT monitors sitting on stations with wheels that a clinician is actively wheeling around between patients and entering data into this big hulking machine between patient consultations. Now, on that system is deployed a medical record, which is an application that sits on that particular machine, and the clinicians spend most of their time interfacing with that single application. There's workflows within that application. So the largest electronic medical record used in New South Wales Health is called Cerner. It's made by a vendor called Cerner. It's the Cerner EMR. And their particular product that we use in the emergency department setting is called FirstNet. So there's standard workflows that have been deployed. And within those workflows, there's opportunities for alerts to appear. So it's effectively a pop-up that blocks the screen. And you can see from an alert fatigue standpoint, if these pop-ups are constantly coming and 90% of the time they're not relevant, the clinician just gets used to pressing X and switching off and not paying attention to them. So what we're doing with our particular product for our proof of concept, or pilot at least, is not integrating into the Cerner EMR. We're intentionally separating our product from it, so it's not to muddy the waters with the preconceived notion of alerts in that particular system, using a tablet device with just the front of house coordinator, who has a more stationary role within the emergency department waiting room. They don't need to run around as much between clinical visits, and allowing them to use that device to assess the quality of this particular risk stratification. And what we are proposing isn't strictly an alert, it is a risk stratification. So we're not throwing an alert saying this patient does and this patient doesn't have sepsis. We're giving patients a risk score and explaining why we're giving them that risk score. So the front of house coordinator can look at a patient and think sepsis when they're looking at that patient, and combine the reasons that we think they have sepsis with what they're seeing in front of them to come to a more balanced decision from their clinical perspective, whether or not that patient needs to be escalated up the triage categories and put in front of a clinician and most likely treated immediately with a broad spectrum antibiotic as they progress down the sepsis pathways for that more targeted treatment of whatever's causing their infection. Next question from David. Were there any concerns around privacy, compliance, and patient data that you had to cater for in the solution? Excellent question, and massive concerns. So I'd say about 10 months of this project before we could even begin on seeing real world data for patients was all around data governance. So first of all, beginning with the local health district, who from a legislative perspective have ownership of that data. So getting approval from them to use it. And that approval requires us to go through the Health Records Information Privacy Act's criteria that show that we have an appropriate use for that data. So for example, there are some uses of the data that are strictly prohibited that we would not be able to get use without direct consent from each individual patient. But there are some uses of that data where we can make use of the data without explicit consent from those patients. In the process of building this algorithm, we also took additional steps to limit our ability to violate patient privacy. So things that weren't necessary for the model build, such as a patient's name, address, Medicare number, etc., were all hashed before the information was sent to us. So we would just see alphanumeric strings attached to patient records. We wouldn't know who it is. And we kept it on an environment that was locked down from the broader internet, so no one could bring in an external data set of, say, social media data with timestamps that could potentially re-identify components of that data set. There was an audit capability on that particular platform to see if people were performing searches that would result in a small number of returned results, which could be an indication of someone looking for unique patients in the data set. And we were able to flag people who were potentially doing that. We didn't run across anyone in our team who was doing that, obviously. We also did criminal history checks of anyone who got involved in this project. We had everyone sign the New South Wales Health Code of Conduct. We were very clear about how we were using the 5 safes to maximize the privacy of patient records throughout this project. And then at the very end of the day, when it came time to build out the application itself, where it became necessary to connect real patient information to the algorithm, ensuring that we limited access to that particular flow of data to just those ICT specialists who were required to see that information as a part of making the machine work. And again, ensuring they understood their responsibilities, they understood who the owner of the data was, understood that no secondary use of that data was permissible, understood that they were not to look at patient records, etc. So a huge amount of effort put into this space. In reality, you only get one chance to get this right. Any whiff that you've done something untowards in the patient privacy space, and everything comes crashing down to the point where potentially we can't do these value driving analytics in New South Wales Health for a period of 10 years while this kind of furor dies down. So we are incredibly conservative around our usage of data. We do everything that we can to ensure that privacy standards are not only met, but greatly exceeded. But we do have to counterbalance that against not doing anything. So an easy default position to take would be we can guarantee privacy if we never look at the data, but if we never use this asset, we're throwing a lot of potential out the window to really improve patient outcomes. So it's striking the right balance between the two. I've got Joanna here up next. So with these projects, are the ethical dilemmas with AI being used in the healthcare system? And how can we ensure that these concerns can be minimized among the general public? Let me just share another presentation. So I presented at the AI Summit for New South Wales government earlier on last week, actually, on Monday. Oh, I just got to see if I can minimize. Oh, here we go. Just going to minimize this, share my screen in a second. I've got another presentation where we go more into some of the ethical components of this. So I'll just resume my share. Oh no, sorry, dealing with a technical issue here. My screen has gone a bit haywire. 2 ticks. Let me just try and stop this. Stop that share. Okay, sharing the second presentation now. Is that visible, Varun? Can you see the second presentation?
I think, yes, I can see it. It's not maximized, but I can still see it. Yeah, now it is. Now it is maximized. Thank you.
So this is a really good question to ask. So the New South Wales government back at the start, or maybe even mid-2018, began the process of building out an AI ethics framework for New South Wales government to adopt. Partway through that journey, they realized that it would be more appropriate to create a broader user guide for how AI can be safely adopted by New South Wales government and related industry, where ethics does play a large component of that. So in building out our particular tool, we did really want to ensure that we were approaching it with our eyes wide open and not inadvertently discriminating against certain groups within the population. So what you see on the screen here, oh, sorry, I've moved, is a slide on one of our reporting tools that's used internally to monitor the health of the model through time. At the top, you can see concepts like sensitivity and specificity, which is how well the model is going at detecting sepsis and how many false positive cases it's throwing. So at a broad level, you want to capture as much sepsis as possible, but you don't want to throw too many false positives and disengage the clinicians. But at the bottom of that page, there's an example of the methodology that we're using to track bias within our models, which is a component of ethics of applying AI. So we could apply an AI algorithm, for example, that on average does amazing. It's the best on average model that we could possibly get. But when we start drilling down into subgroups, we discover that, say, for young women, the model really underperforms. It does a terrible job of detecting sepsis for them. Brilliant for everyone else, but terrible for them. If we turn a blind eye to the analysis of bias within our model and which groups it may not be performing well for, we have that that potential consequence of having an unjust outcome for that particular group. So a big part of the methodology for building our model is going into it with our eyes wide open, having an understanding of which groups may or may not have a poorer result for the models that we're deploying, and actively tracking how the model performs for those groups through time. So not assuming that just because it works well when we build the model even, that it will work well forever, giving us that flexibility to reassess every month how our model is performing for different slices of the population and even subgroups within those slices. So we'd have the capability, for example, to build a second model for a subgroup where the overall model wasn't performing well, or go into more advanced areas of statistics where we would get into mixed effect models that allow for more what they say in the statistical parlance, heterogeneous treatment effects, which aren't as common as they should be in AI that's being deployed today. And if there are any statisticians in the room, I could talk about that topic for an entire separate hour. But one thing to actually really interestingly to highlight even now on that, before I go to the next question, is a lot of the decision support we have today, whether it's AI using statistical models or based in the old pen and paper rules, really is that concept of how do I get the best result on average? But the problem is that the average person doesn't exist. I made this joke in the AI summit that the average patient entering an emergency department waiting room has one ovary and one testicle. So how can a result designed to maximize a prediction for that person be effective? And the answer is it can't. There is a lot of growth that needs to occur within the AI and statistics and machine learning space to really allow for heterogeneous treatment effects, is what they're called, to be incorporated into models. But all that really means is allowing different predictions to exist for different subgroups within the population. So not just defining an average person and building the best prediction for that average person, coming up with the best prediction you can for the subgroups that you can identify within that population. something that I'm passionate about. But moving on to the next question, we've got Agam. Apologies if I pronounced that wrong, but how do you test the system for sensitivity and specificity? Yep, good question. So sensitivity and specificity is calculated based on the difference between what the model predicts is going to happen and what actually happens. So what we do is we run this model through time. And what we've done historically to test sensitivity and specificity is build a prediction at one time point and then see what the actual result was a month after the fact. When we go live with this model, what we'll be doing is every month, I'm compiling a report that looks very similar to the one on the screen here, and with the time series in the middle, that tracks how that changes through time. So every month we'll be observing, okay, the model predicted that we'd be able to detect 70% of sepsis cases. In reality, we only detected 60% of cases. So our model accuracy or sensitivity in this case is starting to go down. So that would be a cue for us potentially as the model builders to get involved again in reevaluating whether or not something has subtly changed. When you build a statistical model or a machine learning model, if you really do get it right, if you understand all of the causal relationships between the biological factors that indicate sepsis, you shouldn't need to ever rebuild your model. But if you did get it wrong and all you found were random patterns in the data, random correlations that led you to believe that you'd found a meaningful relationship, then maybe in a month's time, your sensitivity and specificity starts to break down rapidly. So that would be a trigger to come back and reevaluate the model. But it's not just poor model building that can be a cause of this. The reality of the clinical situation is that things change through time. Medicine moves forward. Models of care change. So patients may be treated differently. And the model inherently assumes that patients are being treated the way at the time that the model was built. Likewise, in the world of ICT, there are code upgrades to these systems, and those may break certain data pipelines. And if we're not aware that these data pipelines are breaking, the overall predictive quality of the model may deteriorate simply because it's not getting the data it needs to make a good prediction. So we need to monitor these things to ensure that we're always giving a highly reliable and safe prediction for our patients. David, up next, how does your learning model take into account real-world data of positive and potential false positive results? How often is it expected that the model may require review? Are thresholds part of the POC scope? Yeah, so we've thought in advance what the thresholds would be for a re-review of the model, and they're really based around a large number of false positives being thrown, and that's our front of house coordinator disengaging from the model, or on the inverse, not detecting enough sepsis, so missing too many cases, it getting worse and worse through time. Now, we haven't locked in what these thresholds will be for those two particular metrics right now, because we're going to do a human-centered design process where we sit down with that front of house coordinator, we talk to them about how they're feeling about the predictions, then we're going to bring in the quantitative data and show them what the empirical data says about how well the predictions are forming. And then we'll work with them to come up with thresholds that really make sense, that hit their expectations appropriately for when the modeling team should get involved. And we're going to automate the detection rules. So the operations team for this particular front-end product, who won't be as well versed in the AI components, don't need to go through thousands of metrics themselves that they probably don't understand every day. They can simply look at a simple dashboard like the one on the screen, see that something has gone through a boundary criteria, and get an automated email alert as well when it does, and use that as a flag to get us involved again to re-review what's going on. So difficult to say upfront what our expectations are. One other thing to note too on the sensitivity and specificity is that it is always a trade-off, right? So I could get 100% specificity, meaning I could detect 100% of sepsis cases. Sorry, thinking about COVID, that's obviously at the front of our mind. But I could detect 100% of sepsis cases without any fancy computer algorithm at all, simply by firing an alert when every patient comes through the door saying that that patient has sepsis. Now, a lot of false positives are going to fire, but I'm guaranteed to capture every case of sepsis because I've said everyone has sepsis, and that's not useful to anybody. So it's about striking the right balance. You can always dial up the number of cases that you detect out of the sepsis population, but the higher or the greater the number that you want to detect, the more false positives that you're going to introduce into the mix. So it's about working with the clinicians on finding the right equilibrium point between the two. From an empirical standpoint, we can optimize and find the optimally best equilibrium point. But from a psychological standpoint, and to get the most utility out of this model, there's a big human-centered design piece where we're going to work with the actual clinicians to come up with a sensible threshold for them. Ellie's up next. So were there any concerns around bias creeping into the algorithm? Yeah, so that's exactly what I've been discussing. Very concerned around bias creeping into the algorithm. The biggest concern that we had was around age. So we're running this algorithm at a hospital that predominantly treats adults. But that isn't to say that children under the age of 16 won't present there initially. So if our model is trained on 99.99% adult data and sepsis looks subtly different in children, our model is going to be really bad at detecting those subtle differences and probably won't perform well on children. So we need to keep a laser focus on how we are performing for those children. As a part of that, we're actually partnering with Sydney Children's Hospital Network, as I mentioned on the slide with the collaborators, to come up with a different definition of sepsis for children, as sepsis actually looks different for kids. And from that different definition, most likely a different model for children under the age of 16. So we have this ensemble approach that we'd be moving towards as this model matures, where there would be one model for adults and one model for children. But we need to keep an eagle eye on how it's performing for children and make the clinician aware, right? So if we know our model is performing poorly for, say, men under the age of 16, we need to be very clear when a prediction is performed by the model that we don't have a lot of confidence in this particular prediction because this is for a person under the age of 16 and you should use your clinical judgment. Don't rely on the results of this particular model. So yeah, excellent question and something that we are putting a lot of focus towards. What is the feedback loop for results? Yep, that's a good question. So the application or the front end of this particular tool that's going to sit on a tablet held by the front of house coordinator, that's going to be fed in real time with a underlying relational database that we're going to have a real-time stream of data from. But that's only going to encapsulate the little snippet of information that we care about for predicting sepsis. Knowing after the fact whether or not a patient had sepsis requires a broader analysis of their entire patient journey. It may not be known that they had sepsis in the emergency department until a couple of days at times after they were there, if it was a particularly tricky case to identify and perhaps clinicians went down an erroneous diagnostic pathway. So what we need to do to bring the two together is a monthly extract from the electronic medical record, so a batch extract that looks at that holistic patient journey, applies our algorithmic definition of sepsis to that journey so we consistently define sepsis. We went through a 6-month consultative period with clinical experts to come up with that definition. And then we contrast how our algorithm is performing in real time versus that actual outcomes data on a monthly basis. So that's the feedback loop that we're using for the reports that you see here. Can you give a brief overview on dealing with heterogeneous treatment effects? Yeah, I can. So this is an interesting one, and again, it comes down to that sort of that joke about the average patient has one ovary and one testicle, and the average treatment, which is what is generally being applied in New South Wales health hospitals, isn't necessarily the best for the individual. So there is this concept of the personalization of medicine, where we move towards using genomic data to build better predictions for individuals. But to really make the best use of this, we have to allow our predictions to take into account the unique circumstances of that individual. We can't say that everybody is exactly the same. So we want to use the treatment that has the best result on average across everyone. We want to come to a point where we're able to allow the different treatments that we give to vary subtly based on the unique circumstances of the individual to come up with a result that's tailored towards them down the vein of personalized medicine. And the way that we do that is by applying statistical models that allow for heterogeneous treatment effects. So your normal, if anyone's done a statistics 101 class, the first thing that they probably teach you is linear regression. And this assumes that there is like a homogeneous pattern within the data. So the variance in the data is constant across all patients. So everyone's sort of the same and they all vary around that average patient. But in reality, there are different classes of patients who behave or appear very differently within the data. And heterogeneous treatment effects allows that pattern of variance to look different for those patients, and the models that you build on top of that data to take into account those differences. So you move towards that personalized approach to medicine. You come up with a prediction of sepsis in this particular instance that really is tailored to that individual and not just based on what the average patient should get in that particular circumstance.
Lachlan, in the interest of time, just the last two questions.
Yeah,
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 thank you.
no problem. So Mark, we've got what is the clinician and ED staff feedback? So we haven't actually deployed this product live. They have been, from an intellectual standpoint, intrigued. The idea of reduced alert fatigue resonates with them to a great degree. And we did work with them on designing the actual look, feel, and use of this application through a human-centered design process. So there is buy-in from them on that particular point, but their genuine feedback, and clinicians are brutally honest, and we do intend to take that feedback on board. Won't be known until we go live in April with hands-on experience with this tool, and we're giving ourselves plenty of scope to pivot if a pivot needs to occur, and also fail fast if we're finding that we're not able to have the impact that we're hoping to have as a result of using this tool. And then the final question, as a patient, is there anything I can do to help provide better information to the AI system? Not in the context of this particular product, but broadly speaking, these kinds of concepts are things that from an eHealth perspective, we are exploring. So concepts like patient-reported experiences and patient-reported measures are two new digital collections that we're trying to put forward, whereas today we're very reliant on what the doctors said happened, but not listening to what the patients felt happened or what their experience was like. So by bringing in this information as an additional lens to the models that we build, we're going to have far more profound results that deliver better outcomes for patients, not just in terms of the clinical outcome, but also that experience on the journey towards the outcome as well. I'd like to thank everyone for giving me an hour of your time. It's been a great pleasure to be here. If anyone wants to discuss further, feel free to shoot me an email afterwards. Otherwise, enjoy your days. Catch you later.
Yeah, thank you, Lachlan. That was such an interesting, I would say it was fascinating, the presentation and the topics you discussed. And thank you so much for sparing your valuable time and taking all the questions from, it was a very participative crowd. So thank you once again. And at the end, I'll just like to, inform the viewers that Dharma Australia and Sydney branch look forward to catching up with you for our next event, which is going to be exactly a month from today. That is 16th of March, 2021. And also there is the 7th annual Australian Government Data Summit, which is on 23rd to 25th of March, 2021. You can register by going to the Dharma website and looking for events and training. And once again, if you're not a Dharma member, you can go to the Dharma website, go to the membership and apply for membership. We are a not-for-profit and always strive to help the data management community. Thank you and see you next time. Please take care and stay safe.